Cholecystitis. Acute cholecystitis is the fourth most common cause of hospital admissions for patients presenting with an acute abdomen. The word cholecyst refers to gallbladder, and itis means inflammation. Cholecystitis simply means inflammation of the gallbladder. In a hospital environment, you'll hear or use this word very frequently, and it's one of the common causes of abdominal pain. There are two types of cholecystitis, acute and chronic. Acute cholecystitis is a sudden inflammation of the gallbladder. Chronic cholecystitis is a minor degree of inflammation over a longer period of time. Very frequently, acute cholecystitis develops when gallstones or biliary sludge block the cystic duct of the gallbladder. Gross anatomy. The gallbladder is a pear-shaped, hollow structure with stretchable walls. It's located under the liver in the right hypochondrium of the abdomen. The normal adult-sized gallbladder has a volume of about 50 milliliters and measures 7 to 10 centimeters in length and approximately 4 centimeters in diameter. The gallbladder is divided into three anatomical divisions: the fundus, body, and neck. At the junction of the neck of the gallbladder and the cystic duct, there's an outpouching of the gallbladder wall known as Hartmann's pouch. The neck continues as cystic duct and joins the common hepatic duct to make common bile duct. The sphincter of Oddi is a muscular valve that controls the flow of bile and pancreatic juice into the duodenum. Arterial supply to the gallbladder is through the cystic artery, which is a branch of right hepatic artery. Venous drainage is through celiac vein. Microanatomy. Gallbladder is composed of the epithelium is a thin layer of cells on the inner side of the gallbladder. The lamina propria is a thin layer of loose connective tissue, which, together with the epithelium, forms the mucosa. The muscularis, consisting of smooth muscle fibers that helps the gallbladder contract and squeeze its bile into the bile duct. The perimuscular is a fibrous connective tissue layer that surrounds the muscularis. The serosa is a smooth membrane covering the outer side of the gallbladder. Gallbladder starts developing in the fourth week of intrauterine life from the foregut. Two small outpouchings arise from the developing duodenum called the hepatic diverticulum and the cystic diverticulum, which finally go on to become the biliary tree and the gallbladder respectively. Physiology. The core function of the gallbladder is to concentrate and store bile produced by the liver. Bile flows through hepatic ducts and eventually through the cystic duct into the gallbladder, where it's concentrated about 5 to 10 times and stored. When food-containing fats enters the digestive tract, it stimulates the secretion of cholecystokinin. Cholecystokinin is a hormone which is secreted by cells in the duodenum and stimulates the release of bile into the intestine and the secretion of enzymes by the pancreas. In response to cholecystokinin, the gallbladder contracts and releases bile into the duodenum. Bile is vital for the emulsification of fats. An emulsion can be defined as a mixture of oily and watery liquids. Bile is composed of water, mucus, and bile salts. Bile is made by the liver. Bilirubin is converted into bile salts, which is secreted as bile into the intestines. After emulsifying the fats, about 95% of the bile salts are reabsorbed into the circulation from the terminal ileum. Pathogenesis. The pathogenesis of acute cholecystitis is frequently due to obstruction of biliary outflow, most commonly by a stone or thickened and concentrated bile, and rarely by other causes, such as stricture, kinked cystic duct, polyp, torsion of the gallbladder, extrinsic pressure on cystic duct, such as that of lymph node or tumor. The entire gallbladder becomes inflamed and swollen. As the gallbladder swells, the blood vessels in the gallbladder wall become compressed, causing extensive ulcerations and gangrene on the fundus, which can rupture and produce biliary peritonitis and is responsible for a very high mortality rate. When the inflammatory exudates surrounding the gallbladder collect under the diaphragm, it results in pain, radiating to the right shoulder due to phrenic nerve irritation. Antibiotics can completely treat the condition, but recurrent attacks are common. Perforation can also occur when the stone is impacted in the Hartmann's pouch. Empyema of the gallbladder can also occur in diabetic patients and is associated with high-grade fever, chills, rigors, and even septicemia. Gangrene of gallbladder occurs if the blood vessels get thrombosed. All these features are more in an obstructive variety. Diabetic patient can possibly have infections caused by anaerobic bacteria, in which case extensive gas production in biliary tree and associated toxicity and perforation is likely even without stones.